Good evening and thank you everyone for joining us today. I, Amit Saxena, along with my colleague Dr. Deepika Chabra from Medical Services, Jagsonpal, are pleased to welcome you all to this month's AOGD Delhi PG Forum on case-based discussion by our postgraduates of VMMC and Safdarjung Hospital in New Delhi. This is knowledge sharing initiative of Nari division of Jagsonpal, makers of LycoRed Preg, Maintane 250-500 hydroxyprogesterone injections and DIVATRONE 10 mg tablet fully indigenized micronized dydrogesterone, the only brand having 36 months of shelf life. We would like to express our gratitude and warm and hearty welcome to esteemed experts and attendees. We request you to post your questions, suggestions, clarifications via text in Q&A box or chat box. This webinar is streaming live on Facebook and link will be shared in the chat box. We are now sharing the YouTube link for you to watch in the future. Now requesting coordinator Delhi PG Forum, Dr. Sunita Malik, and co-coordinator Delhi PG Forum, Dr. Shivani Agarwal, to start the webinar.
New Year to everyone. It's the first webinar of today's 2023, and I welcome you all to this webinar. And it's really a very popular and interesting program where the postgraduates of Delhi, they discuss various cases, and today's case is going to be discussed by the Safdarjung team, and it's on renal disease in pregnancy. We know that we have dealt with the case of APH, and we are very happy that we have delivered the baby, and later on she lands up into acute renal and that renal failure, AKI, that's what we call it. Or she could be a chronic case of chronic renal disease and then acute episode, or the same patient line goes into renal chronic phase later on, and we have to manage. So all this is going to be discussed under table guidance of Dr. Josna Suri and Dr. Ratna Biswas. It's under the chairmanship and the presidency of Dr. Asmita Rathore. As we know, she is Director Professor and Head of Obst and Gynae at Maulana Azad Medical College and Hospital, New Delhi. And she's president of AOGD. She's got many publications and research and chapters and books she has written. And she was also president NARCHI in 2022. Next, we have Dr. Anjali Dabral. She is head of Department of Obst and Gynae at VMMC in Safdarjung Hospital. She is very much interested in high-risk pregnancy, has also done fellowship, WHO fellowship in high-risk pregnancy, faculty of IP University, published many papers, life member of many institutions, NARCHI, AOGD, ISCCP, and she's also got interest in gynae endoscopy. The next chairperson is Dr. Adarsh Kumar. He is assistant professor in Department of Nephrology and Renal Transplant Medicine, VMMC in Safdarjung Hospital, a young fellow. So he's going to give his expert comments along with in this case. Ratna Biswas, she is the Director Professor, Lady Hardinge Medical College and SSK Hospital, New Delhi. She is member of Medical Education Society of FOXI, Vice President IMS Delhi Chapter, Editor of AOGD Bulletin in 2019, Secretary AOGD, Joint Secretary AOGD, and has got many achievements, awards in her name. And she has a special interest in critical care obstetrics and gynae oncology. Next, we have Dr. Josna Suri. I think she is very famous, and everybody knows her as a critical care specialist all over India. She's been Vice President of AOGD in 21-22, National Corresponding Editor of Jogi, Chairman of so many committees, and she is in charge of critical care obstetrics of Safdarjung Hospital since its inception 2016. And she's been awarded WHO Fellowship in reproductive endocrinology, and many prizes, research publication, books and chapters are there in her name. And then we have our 4 young postgraduates, very enthusiastic: Anuradha Sharma, Shailja Kumari Jha, Kajal Bareja, and Yashi Nagar. Now I will ask Dr. Anjali to say a few words.
Good evening, everyone. As we know, the incidence of renal disease in pregnancy is rising exponentially. A lot of it, as said earlier by Madam, is related to increasing incidence of hypertensive disorders. And we are seeing a lot of chronic medical renal disease. Maybe it is linked with the fetal origin of disease. Anyway, so without further ado, we are getting along with the class.
Dr. Asmita, you want to say a few words?
To wish everyone a very happy new year. And would also like to congratulate Dr. Sunita, Dr. Shivani for conducting this PG forum extremely well, which has now entered into another new year and a new milestone.
Thank you.
And topic, I think enough background has been made today. So without doing much formalities, I would like to request you to start the scientific activity. Thank you, Dr.
Okay, over to you, Dr. Josna and Dr. Ratna. Please start today's class.
Yeah, thank you, ma'am, for the kind words and for giving us this topic. We have 4 students here today, so they are going to, in short, we will be showing the case summaries and then discussing those cases. So, Yashi, we'll start with you. So you can tell us what are the physiological changes in pregnancy in the renal system, which impact the clinical care and the clinical significance basically of these changes.
Yes, ma'am. The physiological changes which happen in the renal system in normal pregnancy are there's an increase in the kidney size approximately 1 centimeter, which returns to normal in the postpartum period. There is dilatation of the renal pelvis as well as the ureteric dilatation, which resembles hydronephrosis on sonogram or intravenous pyelography. Therefore, it can be confused with obstructive uropathy, and retained urine leads to collection errors. Renal infections are more virulent and they may be responsible for distension syndrome. Therefore, elective pyelography should be deferred for at least 12 weeks postpartum. Glomerular filtration rate and renal plasma flow increase by 50%, which leads to a decrease in the serum creatinine level during normal gestation. A level of more than 0.8 milligram per deciliter creatinine is already considered borderline for pregnancy. There's an increase in excretion of protein, amino acid, and glucose. There's a decreased bicarbonate threshold, and the progesterone stimulates respiratory center. The serum bicarbonate is decreased by 4 to 5 milliequivalents per liter. The partial pressure of carbon dioxide is decreased by 10 millimeters of mercury, such that a partial pressure of carbon dioxide of 40 millimeters of mercury in pregnancy is already considered to be carbon dioxide retention. The osmoregulation is altered, and osmotic thresholds for vasopressin release and thirst decrease, and there is the hormonal disposal rates increase, such that during normal gestation, increased metabolism of vasopressin may cause transient diabetes insipidus during pregnancy, and a serum osmolality decrease of 10 milliosmol per liter is seen.
Okay, so that means that in a nutshell, you are telling us that a pregnant woman has got, I think the most important thing from here is that they are prone to having infections. Yes. And second is that the normal values in pregnancy have to be interpreted differently. Yes. I think these are the 2 most important messages you have given. So what are the common renal conditions which you can see in a pregnant woman?
The common renal diseases that we can see in pregnant women are urinary tract infections, which are further divided into asymptomatic bacteriuria, cystitis and urethritis, and acute pyelonephritis. Then there is acute kidney injury and chronic renal disease.
Okay. So about the urinary tract infections, you said that a woman is much more prone to a UTI. So can you just quickly tell us what are the conditions in the the physiological changes specifically, and what makes a woman more prone to the UTI?
Yes, ma'am. Ma'am, in pregnancy, there is increase in the bladder volume. There's decrease in detrusor tone. There is incomplete voiding, which leads to stasis of urine, which predisposes to UTI. Then there is presence of glycosuria, amino aciduria, and there is a fall in osmolality. And there's a decrease in mucosal interleukin-6 levels, which is responsible for the excretion of the bacteria, which again predisposes the patient to urinary tract infection. At the level of the ureters, there is ureteric dilatation, which leading to stasis, and further, which can be one of the reasons for increased risk of UTI. At the level of renal parenchyma, there is increase in renal blood flow and immunomodulation during pregnancy, which leads to risk of UTI.
Okay. So, Dr. Ratna, you want to make any comments about these particular what the students have?
No, it's fine. We are just talking of the physiological changes. So most important is to remember, as she said already, that the serum creatinine is much lower than what is in a normal patient. So anything beyond 0.8, or if we see doubling, like especially in preeclampsia, we say if it's a doubling. So if it can be anything between 0.4 to 0.8, So even a 0.8, if it is 0.4, then it becomes 0.8. So that becomes abnormal if it was initially 0.4. So that is what we must remember, that the parameters are different. And yes, we are talking about infections. So infections are more common in pregnancy. Yes, we can continue with that.
Yes. And one more thing, I think, which we have to one more thing, I think, which students should remember, that the urine albumin in the normal, non-pregnant, it should be less than 30 milligram per day. But in a pregnant woman, it may be as high as 300 milligram per day. So beyond 300, we take as pathological, but otherwise it is much higher. It is 10 times higher, the excretion of protein in the urine. So these are, I think, the important changes. So now there is one case which Dr. Shailja,
Yes,
can you just tell us briefly the summary of the case so that we can do the discussion about this? Yes, you can read the case out.
Good evening, everyone. The case is Mrs. X, presented in gynae emergency as Gravida 3 Para 2 Live 2 with 31 weeks, 4 days period of gestation with pain, lower abdomen, loin pain and fever since 3 days. On examination, patient was febrile, 102°F fever was noted. Pulse rate of 130 per minute was there. Respiratory rate of 26 per minute and BP was 90/60 mmHg. On auscultation, bilateral air entry was normal, no added sound was heard. On cardiovascular examination, and S1 and S2 was heard. Costovertebral angle tenderness was present or was elicited. On per abdominal examination, uterus was 30 week size, cephalic, fetal heart was present and regular. Uterus was relaxed, non-tender and non-tense. On PS examination, cervix and vagina was healthy, no discharge per vaginum was seen, and OS was closed. Lab investigation showed all ANC investigations were normal except urine RM, which showed 25 to 30 pus cells and bacteria was there.
Okay, so what is your diagnosis then in this case?
Ma'am, my diagnosis is G3P2L2 with 31 weeks plus 4 days of period of gestation with acute pyelonephritis.
Okay. So before we talk about what is acute pyelonephritis, can you tell us about how what are the different ways in which you can suspect whether somebody has cystitis, pyelonephritis, because you said you have made a diagnosis of pyelonephritis.
Yes, ma'am.
Yeah.
Ma'am, when a woman comes with a urine culture report of significant bacteria, which means a quantitative bacterial count of 10 raised to the power 5 colony forming unit in per ml voided urine, and a patient only has significant bacteria in the absence of any urinary symptoms, then a diagnosis of asymptomatic bacteria is made. But if in the presence of significant bacteria along along with urinary symptoms, then the patient is asked for clinical symptoms such as dysuria, urgency, frequency, nocturia, hematuria, and suprapubic discomfort. If patient has these complaints and no other systemic symptoms involved or no other systemic symptoms elicited, then a diagnosis of acute cystitis is made. But if a patient, along with these symptoms, if a patient complains of fever or a costovertebral angle tenderness is elicited, then the diagnosis of pyelonephritis is made. In my case, the patient had fever, loin pain, and costovertebral angle tenderness was elicited. So I made the diagnosis of pyelonephritis.
You can add something to the diagnosis further on. Her respiratory rate is 26. Her blood pressure is low. So what is the quick SOFA score? Is she in sepsis or she is not? Did you calculate her quick SOFA score?
Yes, ma'am. Ma'am, her systolic BP is 90 and pulse rate is 130. Then the quick SOFA score is of 2. So, ma'am,
so her mean arterial pressure, did you, you have to calculate the mean arterial pressure, no? And the respiratory rate is high. If mean arterial pressure is less than 65, then she has a score of 2. That means she has a positive quick SOFA score, right?
Yes, ma'am.
She has a tendency to go into sepsis.
Okay. So, Shailja, so you said the patient has, so what is exactly pyelonephritis? What do you understand by pyelonephritis?
Ma'am, pyelonephritis is acute, defined as infection in upper respiratory tract involving both renal pelvises and parenchyma.
And you have written the risk factors also.
Yes,
so
ma'am.
Risk factors for pyelonephritis?
Ma'am, pregnancy itself is a risk factor for a urinary tract infection, as already explained. Due to increased bladder volume and decreased detrusor muscle, there is stasis of urine which leads to urinary tract infection, and other predisposing risk factors which can be poor hygiene, advanced maternal age, low socioeconomic status, maternal diabetes, and sickle cell anemia can lead to pyelonephritis.
Yeah. Besides that, you know, not just the stasis, but also there is a reflux.
Reflux.
Reflux is there. So that also promotes the passage of the bacteria from the lower urinary tract to
the kidneys.
Yeah. So okay. So now now that you have this case, and probably as Dr. Ratna has seen that she is probably, you know, having going into sepsis. So now how would you manage this case? Would you want to admit her, or we can treat her in OPD basis? And what should we do with this case?
Ma'am, every patient of pyelonephritis should be hospitalized in the patient, and inpatient treatment should be given to the patient. Vital monitoring along with the urine output monitoring has to be done on daily basis. Lab investigations such as hemogram, kidney function test, serum electrolyte, urine culture, and blood culture along with ABG with lactate levels should be done to look for sepsis. Adequate hydration should be maintained. Urine output should be maintained more than or equal to 50 ml per liter with intravenous crystalloid solution if required. And symptomatic treatment can be given to the patient if required. IV antibiotics are given. Chest X-ray is done if patient complain of dyspnea or tachypnea to look for ARDS, and repeat lab investigations are done after 48 hours of a patient admitted in the hospital.
So what can you tell us more about the antibiotics? Which antibiotics do you prefer?
Yes, ma'am. According, this is this is a flow chart showing when a patient comes with fever or renal angle tenderness along with a report of significant bacteriuria, diagnosis of pyelonephritis is made. And as I explained earlier, patient is admitted and all her routine investigation and urine and blood cultures are sent and treatment is started. IV antibiotic is given according to the mild to moderate and severe acute pyelonephritis are looked. As in my case, the patient has a Q-SOFA score of is going in sepsis. It is more towards severe acute pyelonephritis, and I would prefer ticarcillin with clavulanic acid or piptaz or meropenem. Whereas in mild to moderate cases of acute pyelonephritis, ceftriaxone, cefepime, amoxiclav or azithromycin can be given. Ma'am, after looking all these, I will postpone the pregnancy till the patient is afebrile, if there is any indication to delivery. If the and temperature charting is done in hospital, and after 48 hours, I will look whether there is fever or not. If fever is patient respond to IV antibiotic. IV antibiotics are switched over oral antibiotics for 10 to 14 days according to antibiotic susceptibility. And after 1 week of antibiotic coverage, that is after 14 days of oral antibiotic, I will again repeat a urine culture report to look for whether the culture is sterile or positive growth is there. If the culture is sterile, so the low dose suppressive oral chemotherapy, chemoprophylaxis can be is offered to the patient. That is nitrofurantoin 50 to 100 mg at night time is given till rest of the pregnancy, and delivery is done at term as normal patient. And if fever is do not subside within 48 hours of IV treatment, then I would repeat the blood culture, urine culture, and look for whether change in antibiotic is required or not. And a renal ultrasound is done to rule out renal tract anomaly. If
anything else, why we do the renal ultrasound?
Ma'am, renal ultrasound is done to look for the morphology of
some other findings.
Yes, ma'am, and we will see to look for the other findings in the kidney. That is whether there is an abscess, as patient has pyelonephritis and signs towards sepsis. To look for abscess in kidney.
Yeah, so you have to rule out. Yeah.
Yes,
very good. We have seen 2 patients in our hospital also who had an abscess. So I think that important message all the students should carry. Dr. Adarsh, anything you want to add about this suppressive oral chemo, the antibiotics till the delivery? Do you also prefer to give?
Yes, ma'am. As per literature, we should give.
Yeah, because we were having some conflict about it. Some people are not in favor to give it because like at 31, 32 weeks now, our patient has come. So we continue to give her till 40 weeks or 38 weeks, this suppressive, even if her cultures are negative, because some books don't mention. However, some other books are mentioning that we should give. So what is your final opinion you feel we should give them?
From standard book also, like what we have read in my DM time, they also mentioned that suppressive therapy should be given. And other indication of suppressive therapy also, if the even if there is a more than 2 episodes of cystitis also, then also chemoprophylaxis is given till delivery.
Till the delivery.
Yes,
till the delivery. Okay. Okay. So I think
any role of any interventions like drainage or something if there's persistence of abscess.
Maybe if it will be complicated.
Cutaneous
nephrostomy.
Yes,
ma'am, as told us, sometimes the patient is not improving with the standard antibiotic culture. Then we need to do ultrasound. If it is complicated and abscess is there, then definitely if the patient is not improving with the antibiotic, then there is indication of nephrostomy. But all the pros and cons should be explained to the patient, what are the risk involved.
Sometimes can we put a pigtail drainage or something also?
Yes, ma'am. If the patient is not recovering with the antibiotic as per culture sensitivity after 5 to 7 days, then definitely there is indication.
Okay. Okay, so because that deep-seated, I think abscess, until it is drained,
Yes,
sometimes the patient may not respond without that. Okay, so I think this thing is very clear, and thank you for clearing this doubt. Dr. Ratna, are you people also giving continuous suppressive chemotherapy after pyelonephritis?
Actually, I have not encountered too many cases of pyelonephritis. And one or two cases we have not continued with the
Yeah, so
antibiotic.
this was,
Actually, we delivered only basically.
yeah, mostly they come nearing term only.
Yeah.
But if they come early, then I think this is important. We have all learned very now categorically that we should give them suppressive therapy till they deliver.
My controversy is also there with the treatment of asymptomatic bacterial pregnancy.
Yeah.
But still we are giving till now.
Okay. Even after 2 episodes of cystitis, you said you are giving, no? Okay. So now we will be talking a little about asymptomatic because these cases are so common. So we thought that we must discuss about this. So Shailja, the next question which I want to ask you, first I'll ask you what are the complications of this you have already told us. So what are the complications of pyelonephritis, and then we will go on to asymptomatic bacteriuria. Yes, so these are all the, okay, you can just quickly enumerate them.
Ma'am, pyelonephritis can lead to acute kidney injury, ARDS, sepsis and septic shock, MODS, preterm labor and intrauterine death.
Yeah, so it is something to be really feared, I think, and we have to treat it very, very aggressively, mainly in the HDU setting if that is available, I think, because they should be continuously monitored. Okay, so now can you tell us what is asymptomatic bacteriuria and whether it is important to treat it? What are the risks associated with it?
Ma'am, when a high level of growth of a single bacterial organism, that is more than 10 raised to the power 5 colonies per ml on a urine culture, but patient does not have any symptoms or sign, is called asymptomatic bacteria. All pregnant women should be screened for risk screen for asymptomatic bacteria with the urine culture in the first prenatal visit for preferably during 12 to 16 weeks of gestation.
Okay, why is it that you should do it in the first prenatal visit? Is there something important about this?
Ma'am, because all the renal changes in pregnancy occurs mostly during the first trimester, and also early in the first trimester. 6 to 8 weeks, all the changes starts occurring. So it is very important to rule out. It is more chances of stasis and vesicoureteral reflex during the first trimester only. So asymptomatic bacteria could be elicited and treatment should be started so that it does not lead to the complications.
Right. Okay. So what are the complications you say?
Ma'am, it can lead to maternal complication and fetal complication. If asymptomatic bacteria is left untreated, it can lead to 30% risk of pyelonephritis. Acute cystitis can be there. Preterm labor or preterm delivery can occur. It can lead to anemia, chorioamnitis, and postpartum endometritis. Whereas
so I forgot to ask, what is the incidence of asymptomatic bacteriuria in the pregnant population?
2 to 7% is the risk of asymptomatic bacteria in India.
Okay, so that's a big number, right?
Yes, ma'am.
Okay.
And ma'am, in fetus, it can lead to prematurity, low birth weight, increased perinatal mortality, fetal growth restriction, stillbirth, and it can also lead to mental retardation and developmental delay due to the bacterial endotoxin damage, which can cause fetal cerebral hypoperfusion and leads to mental retardation.
Okay, and now about the treatment, what antibiotics and how long do you think we should be treating this?
Ma'am, first, as already said, that screening of all antenatal women should be done in the first trimester, preferably during 12 to 16 weeks of gestation, and diagnosis should be confirmed. In cases of asymptomatic bacteria, it can be an outpatient treatment, and the oral antibiotic can be prescribed to the patient, such as beta-lactam and nitrofurantoin. Nitrofurantoin can be given at a dose of 100 mg BD for 5 to 7 days. And after the completion of treatment, repeat urine culture is done after 1 to 2 weeks of treatment. And if still the culture is positive, we have to treat according to the culture report. And if the culture is negative, further treatment is not required in cases of asymptomatic bacteria.
Okay.
Also ask them to take plenty of fluids.
Yes, ma'am.
And nitrofurantoin, it should be the MR, the sustained release one, if you're giving a BD dose.
Yes, ma'am. And QID
Otherwise,
if I'm giving nitrofurantoin.
Yeah.
Yes, ma'am.
Okay. So any role of the suppressive therapy also in this?
Yes, ma'am. As already stated, after the treatment of asymptomatic bacteria with antibiotic is covered, after 1 to 2 weeks, again urine culture is repeated. And if it is negative, then monthly urine culture is done till pregnancy is completed. But if culture again comes out to be positive, it is called recurrence of the asymptomatic bacteria. And according to the culture, same treatment for longer course duration can be given, or a different antimicrobial in the standard regime can be given. Suppressive therapy is given, ma'am, in cases of recurrence and not in all asymptomatic bacteria patient. Nitrofurantoin 100 mg HS for rest of the pregnancy is continued in this case also, ma'am.
Okay, so in recurrence, we will give suppressive therapy for the rest of the pregnancy. Dr. Adarsh, what is your opinion about giving phosphomycin in asymptomatic bacteriuria? Do you think it is useful?
Ma'am, I think it can be given, ma'am. Actually. But I don't know whether it is teratogenic in pregnancy or not. But
no, it's not. It's not teratogenic. It's not teratogenic.
In that population, ma'am, it is given.
Okay.
And what about in the third trimester giving nitrofurantoin?
Ma'am, in third trimester, it is usually avoided as it can lead to
what happens to the neonatal, any neonatal problems if you're giving in the third trimester?
With nitrofurantoin, ma'am.
Why do we avoid in the third trimester?
Ma'am, it can lead to jaundice and kernicterus.
Yes.
So that it binds to the albumin, no?
Yes, ma'am.
So it
and
may
metabolite.
Yeah. Somebody
has posted neonatal hemolysis. No? Yes. So better to avoid it in the third trimester.
So I think we have covered about the infections. Any other comment from Dr. Ratna or Dr. Adarsh? Then we can move to the next case.
We can move to the next.
Okay. So thank you, Shailja. So now we move to the next case. Dr. Anuradha, you can read the next case.
We have 3 cases.
Yeah, this one is of AKI. Then we have one on the chronic kidney disease.
Okay.
Yeah.
Good evening, everyone. I am summarizing a case. A 27-year Paravan Livan was referred from private hospital on postnatal day 1 to gynecology casualty with complaint of decreased urine output and shortness of breath. History of blood loss after delivery followed by multiple blood transfusion at referral center present. There is history of pain, abdomen and bleeding per vaginum before delivery. On examination, pallor present, pedal edema is present, pulse is 86 beats per minute, blood pressure is 178 millimeter of mercury, respiratory rate is 32 per minute, SpO2 is 90% on room air. On auscultation, chest auscultation, there is bilateral crepitation was present. Urine output was 20 ml in last 24 hours and urine albumin by dipstick method is +1. On investigation, hemoglobin is 8.2, total leukocyte count is 15,000, platelet is 1.20 lakh. Kidney function test are urea is 20 and creatinine is 4.3 milligram per deciliter. Serum electrolyte are hyponatremic, sodium is 128 and
potassium is 5.8 millimole per liter.
Okay, so what is your diagnosis?
Ma'am, my provisional diagnosis is 27-year-old, para-1, live-1 on postnatal day 1 with acute kidney injury with pulmonary edema.
So you had said that the patient also had APH before and pain abdomen. So what are you suspecting? What was the history like? Is it significant?
Yes, ma'am. Ma'am, as per history, there is a history suggestive of abruption followed by postpartum hemorrhage. So there could be hypovolemic shock that can lead to acute kidney injury.
Okay.
So how did you get to this conclusion that she has AKI?
Ma'am, as per history, there is a history of pain, abdomen and bleeding PV that is suggestive of abruption, and post-delivery, there is a history of multiple blood transfusion that is suggestive of excessive blood loss, and this can lead to hypovolemic shock, and urine output is 20 ml in last 24 hours. That is
important, you know.
Yes, ma'am.
So
And
urine output and serum creatinine levels.
Yes, ma'am.
These two will guide you that she has gone into AKI.
Yes, ma'am.
More than 12 hours, less than 0.5 ml per
0.5
kg.
ml per kg per body weight in last 12 hours is significant.
AKI or a serum creatinine which increases.
More than 0.3 mg per deciliter in 48 hours, ma'am, if baseline is there.
She has a very high level.
Yes,
4.3.
Yes, ma'am.
Okay. So how do you define? You have already told us that why you suspect AKI in this patient, but what is the formal definition for AKI? And what are the classification? How do you define and classify the AKI?
Acute kidney injury is defined as sudden impairment of kidney function over days to weeks that leads to retention of nitrogenous and other waste product that is normally excreted by kidney. And the there is various defining criteria and not specific to pregnancy. We follow generally KDIGO classification, that KDIGO stand for kidney disease improving global outcome. According to this, if there is increase in serum creatinine by 0.3 milligram per deciliter within 48 hours, or increase in serum creatinine more than 50% the baseline, which is known or presumed to have occurred within prior 7 days, or if there is urine volume less than 0.5 ml per kg per hour for 6 hours. So it is defined as acute kidney injury.
Okay, so that is the one which you have told us, that is the stage 1.
Yes, ma'am.
So, and the other criteria which you have written, that is the rifle and the Aiken criteria.
Yes, ma'am. For diagnosis, we use Aiken and KDIGO criteria, and rifle we use for the staging. And if patient is needed for renal replacement therapy, that is classified as stage 3. And if renal replacement therapy required for more than 4 weeks, then it will classified as lows. And if it is needed for more than 3 months, then it is classified as end stage renal disease.
Yes. Okay. So this is how you have classified. So this patient has already had a very high creatinine, and her urine output is practically, she's gone into anuria. So
yes,
she has gone straight away into the 3rd class, stage 3.
Yes, ma'am.
Right. Okay. So now, what about the risk factors? Is AKI a common condition?
Yes, ma'am. AKI is a common condition. As per obstetric, there is a hypovolemia is a major cause, and true incidence estimation is difficult because there is a different diagnostic criteria for diagnosis acute kidney injury. According to the text, there is a 2.68 per 10,000 live birth is incidence, and higher incidence is mainly in the developing countries because there is less antenatal care availability and illegal abortions practice are performed.
But in our own HDU, you see that out of the 12 beds, most of the time we have 2 or 3 patients of AKI who are on dialysis.
Yes,
so Dr. Adarsh and his department are really supportive for doing all the dialysis for our patients. And most of them do recover, so it's very heartening for us. Okay, so what are the causes of AKI in pregnancy? Can you tell us a few important causes?
Yes, ma'am. Ma'am, there is causes of acute kidney injury are some of our pregnancy specific, and it could be pregnancy non-specific also. In pregnancy specific, it can be further divided into pre-renal, renal, and post-renal. In pre-renal, it can be dehydration secondary to vomiting, as in early pregnancy, hyperemesis gravidarum. It can be due to massive hemorrhage, as in placental abruption and placenta previa, postpartum hemorrhage, and it can be due to sepsis, and in pregnancy specific, that is chorioamnitis and purpural sepsis. In renal causes, it can be due to preeclampsia, HELP syndrome, acute fatty liver of pregnancy, fluid embolism and DIC, chorioamnitis and purpural sepsis. And post-renal causes can be trauma due to ureter and bladder at the time of cesarean section, obstruction due to enlarged uterine fibroids.
Okay.
And in
Anuradha, that point is very important, that sepsis can lead to both pre-renal as well as renal.
Yes, ma'am.
And even any cause of hemorrhage, initially it may be pre-renal, but then later on it can lead to the ischemic changes and cause, the renal tubular, it can lead to the ATN, acute tubular necrosis, as well as the renal cortical necrosis also, if the ischemic changes persist. So this division from pre-renal to renal is a I think continuum, right?
Yes, ma'am.
Yeah. Okay. Next, please. Yeah. Next, you were telling about not pregnancy.
Yes, ma'am. There is a list of causes which are not pregnancy specific. These are also again divided into pre-renal, renal, and post-renal. In pre-renal, it may be due to dehydration, as in case of acute gastroenteritis, congestive heart failure, and sepsis. In renal, there can be thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, new onset glomerular disease, or acute tubular necrosis and acute cortical necrosis. In post-renal, it can be due to obstruction from bilateral renal stones.
Okay. So you are talking about pre-renal and renal. So is there a difference in their prognosis? Which one are we more, worried about? Which one is the reversible one?
Ma'am, pre-renal are reversible, and we generally in our practice we face pre-renal due to hypovolemic shock. We face generally pre-renal causes of acute kidney injury.
Right. If you see them in the early stage one, they are
completely
times
reversible.
So how would you prevent?
Ma'am, timely diagnosis and adequate fluid management is the key point for prevention of acute kidney injury.
So how would you manage the fluid intake in this patient?
Yes, ma'am.
How would you have managed? Suppose she had come to you. You would have not let her gone into renal, right?
If she had PPH in your labor room.
You are managing it. So what will be your resuscitation, method of resuscitation?
Ma'am, first of all, we will stabilize the patient, and we will prevent further kidney injury for managing hypovolemia. For by the time blood products are available, we will arrange, we will resuscitate. Fluid resuscitation will be done by the crystalloid, and we will give in IV fluid in a bolus. In case of PPH, we will give fluid 1 liter in first 15 to 13 minutes, and next 30 to 45 minutes we will give another 1 liter of fluid. So by giving fluid resuscitation, we will prevent acute kidney injury.
Yes, important is to maintain the renal perfusion.
Yes, ma'am.
So hypovolemia has to be managed aggressively till such time you get the blood products. Yes. By 1 hour you will get the blood and blood products.
Yes, ma'am.
So by that time, very rightly said that you must give at least 2 liters of full fluids before. You should not wait that blood is coming. Start your resuscitation.
I think that is the very, very important point which Dr. Ratna has highlighted. All of you must carry this message with you, that this, to some extent, prevention of AKI is in our own hands, because PPH is a very common occurrence in our labor rooms. So we have to be very liberal in giving the fluid before the blood comes. And now that you have discussed about the fluid management, Anuradha,
Yes,
Are
ma'am.
there any methods of knowing that whether the patient is fluid responsive or not, whether you can give her more boluses of fluid? So what are the methods by which you can, decide about further fluid management?
Yes, ma'am. Ma'am, initially for hypovolemia, we will give bolus, and
You
after.
have a slide you can show that
Yes,
about the
ma'am, after giving bolus for further evaluation, we can do bedside test, that is passive leg raise test. In this condition, we will take BP in the position head end is elevated at 45-degree angle. Then again, we will do BP in the position after 1 to 3 minutes of position that passively raised leg. If there is a pulse pressure is more than 9% in both the situation, that is indicative of fluid responsiveness. This we can do in bedside. And another method is ultrasound. We will do ultrasound by inferior vena cava measurement by the cardiac probe, which is put on the right atrium, 3 centimeter from the right atrium. And if the inferior vena cava is less than 2 centimeter and the collapsibility is more than 50%, that is indicative of fluid responsiveness. And if it is there, we can give more bolus to patient.
So these are very important tests, and I think especially passive leg raising, you can all do even if the ultrasound is not available. Before you give more boluses, sometimes you are confused that can I give her more bolus? Especially because your patient has become anemic, you become very scared to give fluid, that she may go into pulmonary edema. Can I give her fluid or not? So it is very simple test to do, and has got a reasonably fair sensitivity and specificity. So you can do it, putting the legs up is like giving a bolus of 200 to 250 ml of fluid. The blood will go towards the heart. So it increases the cardiac output. And if the pulse pressure increases by 9% or more, you can give another bolus. So after each bolus, you can repeat it also and see. So initially you give fluid, then after giving 1 liter, you can always assess with this and then decide further whether you want to give more fluid or not. Okay, so Anuradha, you have
Yes, this I
spoken
just
about.
want to add a little.
Yeah.
Yes, Dr.
Yeah.
Jyotsna has very rightly said. Sometimes we have to strike a balance between causing pulmonary edema and giving fluids. So these two tests, you can take help of them. And if the IVC is dilated and not collapsing, then we must give smaller boluses for hypotension. Do not give 500 boluses. You can give 250 boluses.
Right. And even if you are not sure about her heart status, because sometimes the patient, see, any patient can have PPH. It can even be a patient with heart disease. So, you can't say that I will not give fluid to a patient of heart disease if she has had PPH. You can't let her bleed to death. So you have to give the fluid, but you may have to give the smaller boluses in such cases. And as Dr. Ratna said, that if there is a bleeding and the IVC is 2 centimeter or more, you give smaller boluses and then you reassess again after giving the bolus. See, in the women with mild CCF and end-stage renal disease, 500 ml boluses. In severe CCF, 250 ml boluses. And in those who have got no heart or kidney condition, you can give even up to 1 liter bolus. So this is what is very important for all of us to recollect when we are facing such challenges. So you were telling us, I think we were asking that how would you differentiate by your investigations pre-renal cause from renal cause? So you have told us that you can prevent, AKI if we have managed the fluids properly. So once it has occurred, so what are the common tests which you can do?
Ma'am, for differentiating pre-renal and renal causes, we will do urine analysis. In pre-renal diseases, there will be normal or hyaline castrases there, and urine sodium will be less than 20 milliequivalent per liter. And in renal cases, there will be muddy brown cast or renal tubular epithelial cell, and urine sodium will be more than 40 milliequivalent per liter. And urine osmolality will be higher side in the pre-renal cases.
apart from the urine analysis, we can do complete blood count with peripheral smear, which is if it is suggestive of microangiopathic hemolysis that can be in renal causes due to the glomerular diseases, and bilirubin, haptoglobin, LDH that is suggestive of hemolysis. And if it is raised in serum AST, ALT, that is again can be in hypertensive disorder of pregnancy, and it can lead, it is suggestive of renal causes of acute kidney injury. And we can do complement protein C3, C4. If there is deficiency, it is suggestive of renal causes. Anti-nuclear antibody, anti-neutrophilic cytoplasmic antibody. Again, these are also suggestive of renal diseases. It can be in autoimmune glomerular diseases. And ADAM-TS 13 level deficiency, that is suggestive of thrombotic thrombocytopenic purpura. And imaging ultrasound KUB also can differentiate between pre-renal and renal. In case of renal, there will be cortical necrosis, scarring will be there.
Okay. So, Dr. Adarsh, would you like to say something about the routine urine examination for our students? You know, it is something very simple, but a very neglected area. I think if you can sum up some, you know, important take-home message for them about importance of doing the urine routine microscopic examination in these cases, especially.
In urine routine, we usually do chemical analysis and microscopy. So in the we see protein, and protein, but we are testing in with the dipstick. We are testing albumin only. It is not the whole. It is albumin only. And apart from presence of protein, we check for RBC, pus cell. These are the routine. And as a bedside, we can simply use this thing, urine sticks in the ward to check all this. And what is peculiar to the pregnancy is that the sample should be collected midstream, because there is a lot of vaginal contamination. So the report can be abnormal. And in some of the cases, the RBC, if RBCs are there, then we need to check whether they are of glomerular origin or urologic origin. And for this, we need to do this thing. They need to be tested in the microscopy whether they are dysmorphic. If they are dysmorphic, then they are of glomerular origin.
So that also gives us a very important information.
And one point is missed, like how to differentiate between the pre and renal. One of the first thing is the ratio of the bun to creatinine ratio. If it is more than 20:1, then it goes in favor of renal AKI.
Okay.
Anything about fractional excretions of sodium and urea? Is it relevant in differentiating?
But fractional this is increased. It is decreased in pre-renal basically.
Yes.
Because of because the kidney is functioning, the sodium is absorbed. So there is a decreased fractional excretion of sodium.
In pre-renal, sodium is actually the body is trying to keep the sodium.
So it is
the sodium is getting absorbed.
Yeah.
So,
so it is excretion if it is less than 1. It is pre-renal, and I don't know, and more than 1 it is written, it is renal. And similarly, fractional excretion of urea more than 35%. That is more suggestive of renal, although nothing is.
Your voice
is fluid responsive, then she is pre-renal. If she is responding to your fluid, she is pre-renal.
Yeah,
she will not go into renal.
Only in the early stages will she respond to fluid. Later, once the AKI has set in, then
it is renal. Then it is renal.
Right. Okay. So, Anuradha, I think we have discussed this, you know, very nicely. You have told us about the differences. So, you have already told us how to prevent. So, here you are trying to say that, role of diuretics. So, is there a role of diuretics in AKI? In which patients should we give the diuretics?
Ma'am, in case of acute kidney injury, we will not, role of diuretic is only in volume overload, not for the treatment of cause of acute kidney injury.
Okay. So it is very important that we don't give diuretics to all the patients who have gone into AKI. So it is not
Yes.
intubated unless there is a patient is in pulmonary edema or there is some volume overload. You are suspecting
Then only we will give diuretics.
yeah. And I think this very important thing which is mentioned, that avoid all nephrotoxic drugs. I think that is very, and dosing according to the creatinine clearance. So most of the antibiotics and all which you are giving, you have to decrease their doses and you don't have to give any of the nephrotoxic drugs.
Yes.
This is very important again. So now I think what is left in your case, you have discussed about everything. So yeah, specific management, I think of the condition, whatever is the condition leading to the AKI, you have to do that. And what about the fluid management? How will you, once the AKI has set in, how much fluid do you give to a patient per day?
30 ml per kg per body weight.
What? No. How much fluid will you give? Once the patient is already in AKI?
Yes, ma'am. Ma'am, we will give maintenance fluid according to the we will do input output charting.
Yeah.
And then total input will be if there is total output per 24 hour plus.
that slide, where is your slide? Yeah.
Ma'am, we will firstly we will do input output charting, and then total input according to the output we will give. Output per total input should be total output per 24 hour plus 500 ml if patient is non-febrile. And if patient is febrile, then we will increase 200 ml per increase per degree Fahrenheit of temperature.
Okay. And plus, if she is having any diarrhea or losing fluid from the right tube or any drain
Yes,
is
ma'am.
put, so
Total
all
loss
those
we will-
also you have to add.
Yes, ma'am. Total
That will be
loss we
extra.
will add.
So
So
is this
Kajal, this patient had, when she had come, you had said that you had taken her serum electrolytes and it was a high potassium. What all things we monitor in the acute stages? What else we monitor and how do we manage in the acute phase of the AKI?
Yeah, you can tell about your
The
hyperkalemia.
electrolyte and the ABG.
We will in this case there is potassium is higher side. We will after excluding
Potassium was not higher. Potassium was 128. Sodium is high.
potassium.
No, her potassium was 5.9 or something.
Sorry, yes, potassium was high. Yes.
First we will rule out the pseudo hyperkalemia, as there can be sample error or we can sample collection error. After ruling out this pseudo hyperkalemia, then we will
how will you rule that out?
Ma'am, we will do resampling for it.
Yeah, and also take the help of a ECG.
Yes, ma'am. After grading the hyperkalemia, mild, moderate, severe.
You can show that slide, Anuradha. Yeah.
Yes, ma'am, I'm showing. Ma'am, after grading the hyperkalemia, which is classified as mild, moderate, and severe. Mild categories is categorized as potassium level is 5.5 to 5.9 millimole per liter. Moderate is 6 to 6.4 millimole per liter, and severe is more than 6.5 millimole per liter. In my case, potassium is 5.9, which is comes under the category of mild hyperkalemia. So we will do potassium monitoring, and potassium monitoring BD means 12 hourly per day. And we will give calcium resonium, that is a 15 gram TDS orally or 30 gram BD per rectally. And if there is a moderate or severe, then we will do ECG for the cardiac changes. If ECG is showing changes, the hyperkalemia changes are first changes are tall T wave, then suppression of P wave, wide QRS complex, bradycardia, and absent P wave is there. If ECG changes are suggestive of ECG changes are there, then we will give calcium gluconate, that is 10 ml 10% calcium gluconate in over 10 minutes slow IV to protect the heart. as there is a chances of cardiac arrhythmia, so we will give empirically treatment for arrhythmia. And if there is no ECG changes, then we will give insulin glucose IV infusion for shifting the potassium into the cells. And insulin glucose IV infusion is we will give 10 unit soluble insulin in 25 gram glucose over 30 minutes. And as there is a we are giving insulin, there is a chances of hypoglycemia, so we will monitor blood sugar in every 30 minutes till 2 hours, and after 2 hours we will monitor blood sugar every hourly. And we can give salbutamol, that is beta 2 agonist by inhaler 10 to 20 milligram by nebulization. And after giving this, we will continue potassium monitoring, and further treatment will be according to the potassium level. If the potassium level is still high, that is more than 6.5 coming to the severe category, we will go for the dialysis.
Okay. So anything more, Dr. Ratna, in this?
What about the ABG?
Ma'am, ABG, in mostly cases, there is a metabolic acidosis, so we will give bicarbonate correction as well.
Yeah.
No, it is more important that you have to monitor the ABG, you know.
Yes, ma'am. Potassium
Because
level.
the metabolic component, if it is not improving, then you should consider dialysis.
Yes, ma'am.
Okay, so Anuradha, you can tell us the indications of dialysis in any patient who comes with AKI, and then we should go to the next case because we are now running out of time. Yeah, so what are the indications of dialysis?
Indications of dialysis are volume overload, that is non-responsive to diuretic therapy, and if there is a hyperkalemia after initial treatment, and if there is metabolic acidosis refractory to medical management, then we can go for the dialysis.
We should go, right, rather.
Yes, ma'am.
Yeah. And others? Uremia?
Uremia, ma'am, symptomatic uremia, if is there, then we should go for dialysis also.
Any uremic encephalopathy or uremic pericarditis? Yeah. So all these are the indications for dialysis.
Yes, ma'am.
Okay. So I think we go on to the next case. Any other comment you have to make, Dr. Adarsh, about this?
Apart from this general indication, is there any fetal indication of doing dialysis?
Sir, there is generally hypovolemia in our practice. There is mostly in postpartum cases. So fetal consideration is less. So we can go for dialysis in antenatal cases.
No, it is in antenatal. Then he is asking, no?
Because urea is considered to be fetotoxic. So is there any cutoff above which, if it is the above level, if the urea is persistently high, then that is an indication of doing dialysis, apart from this general indication?
The cutoff is 90 milligram per deciliter. If it is there, then we should go for dialysis. Because after that, it can lead to IUD.
Because it is fetotoxic.
Yes.
So this level should be persistently high and the volume correction has already been made. Then that is also an indication of doing dialysis, apart from general indication.
Right.
Okay.
I think that's an important point. So if the fetus is in C2, the woman is not delivered, even just a high urea can be important cause for getting the dialysis done. Correct. So now I think we go to the Dr. Ratna. Should we go to the CKD case then?
Yes, I think we are running short of time. But just 2 words about TTS and hemolytic uremic syndrome. How will you suspect or diagnose it?
And
it
why
is one of the
important
important causes of AKI.
Yeah.
Other than HELP, we are very aware of. AFLP also we commonly encounter. But these 2 conditions are not very common. So can you tell us quickly 2 words only?
Ma'am, in these cases, apart from the uremia, oliguria, there can be other features like rash, history of rashes, history of fever.
Specifically, you tell me. In TTS, what is more important? Which symptoms are very important? Fever, they will come. Might come. Both can come with fever.
Yes,
you know, infections both can come with. But with TTS, somebody is already given the answer in the chat
Ma'am,
box. Yes,
ma'am, there can
neurological symptoms are more in TTS, and there the KFTs are not so deranged, right? While hemolytic uremic syndrome, the KFTs are much more, it is a more severe form of AKI, and they can be accompanied with diarrhea, but they are atypical hemolytic uremic syndrome, which is complement activation system not being regulated. In that case, we have where you said that we have to measure we have to do the ADAM-ST to
Madam TS
differentiate
13.
between
Yes.
TTS and
Hemolytic
yes.
uremic.
Dr. Adarsh, can you tell me any role of eculizumab in
Yes.
HUS?
Yes, ma'am. The case reports are there in which it is given, ma'am. Eculizumab. It is a C5
You're
complement
saying that
inhibitor.
prognosis improves with that eculizumab?
Yes, ma'am. But it's a
Are you
very
giving?
costly.
Are you giving?
No, ma'am. It is not available in India.
Oh.
One injection costs 40,000. It is the costliest drug on this earth, ma'am.
So
Oh
are
my
we
God.
what are we doing if we are having these patients of HUS or TTS? Plasma exchange, are we doing that?
Plasma
Plasma exchange,
exchange.
ma'am, yes, ma'am. Plasma exchange we are doing, and we do basically testing, genetic testing, and we do before going for genetics, we do anti-H antibodies. If they are positive, then there is a role of plasma. Otherwise, in genetic mutation cases, there is no role of plasma. Plasma is more of effective in TTP.
TTS and TTS, no?
In TTA, yeah, TTP only it is more effective. If then I think we should go in for the Adams TS test
Level,
and then
yes.
go in for plasmapheresis. That is the treatment. But for
HUS usually occurs postpartum. You know,
yes,
it's more common postpartum.
yeah, kidney is knocked off in HUS. So you have to remember AFLP, it's the liver and the coagulation system. You know, they come with severe DIC, and in TTP it is the neurological, and mostly TTP will be seen in the mid trimester. You can see, you know, the early onset. They may come with eclampsia, seizures, or they may have some neurological deficits. And this HUS is mostly in the postpartum. So this is how you can differentiate. So kidney, liver, and brain. Okay. So you can
Ma'am, my
differentiate.
one question to the speaker. Actually, what is the cause of AKI in this case? Like apart from pre-renal, because the pathological diagnosis they have told it is
Yeah.
abruptio placenta.
Yes, very
But
good.
apart from pre-renal, what was the cause of AKI in this case? It was just pre-renal or something else?
In this case, there is a history of bleeding and pain abdomen that is suggestive of abruption, and abruption can be due to high blood pressure, and this is apart from pre-renal, it can be predisposing from the hypertensive disorder, and it can be due to, it can come under the renal causes of AKI.
How does abruption cause the AKI? Basically, what happens when there is that abruption taking place? What is released?
Ma'am,
Yes.
in case of abruption, there is a high risk of excessive blood loss during delivery, and excessive blood loss can lead to hypovolemia, that is decreased renal perfusion and ischemic injury to the kidney, and it can lead to acute kidney injury.
I think it is answered by the audience only. Because of the release of thromboplastin.
Thromboplastin. Yeah. So that leads to the DIC. Okay. So that is why the abruption, the AKI in abruption is much more severe. And many times it becomes, you know, the irreversible one. So the worst AKI, just simply if it is PPH due to atony, that will recover in most cases. But if it is due to abruption, it will be more often it will lead to ATN and sometimes to cortical necrosis. Cortical necrosis, normally if it occurs, then it is considered to be irreversible. So that is the difference in this condition, you know. So you have, you know, abruption is the worst thing. The AKI
That is why it's very important to monitor your output, you know, in abruption. That is why we say keep monitor your output and your KFTs in abruption.
Okay. So, Kajal, you can go on to your case now.
Yes, ma'am. So summarizing case 3, a 24-year lady, gravida 2, abortion 1 at 24 plus 24 weeks, 5 days period of gestation with known case of chronic kidney disease with anemia, presented to the gynecology emergency with end-stage renal disease, referred from ESI hospital, Jaipur. On examination, the general condition was stable, but on recording the blood pressure readings were 170 by 110 millimeters of mercury. Per abdomen examination corresponded to 24 weeks of gestation. The urine output measure was 50 ml in 24 hours. She is a known case of chronic kidney disease for last 2 years on dialysis. Patient was on weekly erythropoietin till recently in view of severe uncorrected anemia of chronic disease. Erythropoietin was started along with the injectable iron sucrose and elderweight. On investigating this patient, the investigation profile showed a hemoglobin of 7.5 gram per dl and total leukocyte count of 15,900. The KFTs showed urea of 128 and creatinine of 6.9 milligram per dl. Electrolyte showed dyselectrolytemia 128 sodium and 5.8 millimoles per liter of potassium was seen. Urine routine microscopy showed 1 to 2 pus cells and full field of epithelial cells. 2D echo showed mild concentric left ventricular hypertrophy with grade 2 diastolic dysfunction and 60% of left ventricular ejection fraction. Ultrasound whole abdomen was performed which showed bilateral small kidneys with grade 3 raised cortical echogenicity and attenuated corticomedullary differentiation with mild hydronephrosis.
So the diagnosis of your
The diagnosis is 24-year-old gravida 2, abortion 1 at 24 weeks, 4 days period of gestation with chronic kidney disease with end-stage renal disease on hemodialysis.
Okay. So what is a, how do you define, you said it is end-stage renal disease. So what is the definition? How do you define chronic kidney disease?
Ma'am, the standard definition of chronic kidney disease for the population is the presence of kidney damage, usually detected as urinary albumin excretion of more than equal to 30 milligram per day or equivalent, or decreased kidney function, which is defined as the estimated glomerular filtration rate less than 60 ml per minute per 1.73 millimeter square body surface area for 3 or more months, irrespective of the cause. The persistence of the damage or decreased function for at least 3 months is necessary to differentiate between chronic and acute kidney injury.
So I think this 30 milligram rule can't apply to pregnancy as we discussed in the beginning. So
Yes.
we have to, the creatinine clearance or the estimated glomerular filtration rate will be the one which will give us the clue that what is the stage of chronic kidney disease in our patient, in the pregnant woman. So yeah, so you can tell us about any other classification is there for the CKD?
Yes, ma'am. According to the kidney disease outcome quality initiative, the chronic kidney disease is categorized into 5 stages. Stage 1 is when the kidney damage is there with normal or raised GFR more than 90 ml per minute. Stage 2 is kidney damage with mild decrease in GFR, which is 60 to 89 ml per minute. Stage 3 is moderate decrease in GFR, 30 to 59 ml per minute. Stage 4 is severe decrease in GFR, 15 to 29 ml per minute, and stage 5 is kidney failure less than 15 ml per minute of GFR.
Or requiring dialysis, right?
Yes, ma'am.
Okay. So basically, now this patient has gone into, has become pregnant and she was already on dialysis.
Yes, ma'am.
So what are the pre-pregnancy factors which predict, outcome for your patient? Any factors which you can, use to counsel them, and how would you prognosticate these patients?
Historically, it was considered that chronic kidney disease is a contraindication for pregnancy, but now it has been changed. The prognostic factors, like according to the renal impairment, serum creatinine levels are done, and if the serum creatinine level is less than 1.5 milligram, it is mild renal impairment. Moderate renal impairment is defined as serum creatinine between 1.5 to 3 milligram per deciliter. And severe impairment is considered more than 3 milligram per deciliter.
Yeah, and you were telling us about the pre-pregnancy factors?
Yes, ma'am. So a patient with chronic kidney disease, the pregnancy outcome is based on how much is the degree of renal impairment, what is the degree of proteinuria, and how much control is there of the hypertension. These predict the outcome of the pregnancy in patients with chronic kidney disease.
Okay, so I think this is very important, that what is the baseline KFT when she ventured into her pregnancy, and whether she has a control of hypertension, and what is the degree of proteinuria. Very important. I think these three things have to be remembered. So, Kajal, what is the impact of chronic kidney disease on pregnancy and pregnancy on chronic kidney disease? So both things, you can tell us how they impact each other.
Discussing the effect of pregnancy on chronic kidney disease, it is seen that there is deterioration of kidney function and progression to end-stage renal disease is seen in patients who conceive if the serum creatinine is more than 2 gram%, and there is worsening of proteinuria in pregnancy. Moreover, if the creatinine levels are less than 1.5 milligram per dl, the chances of live birth are more compared to creatinine more than 2.5 milligram per dl, where chances of fetal loss are very high. Outcome of the pregnancy depends upon the control of the hypertension. On this, so if a patient not well controlled with where the hypertension is not well controlled, the chances of her developing complications during the pregnancy and developing chronic hypertension or gestational hypertension, worsening of the renal function, and even ending up in permanent renal failure is seen in these patients. Moreover, the fetal adverse effects like preterm delivery, fetal growth restriction, and perinatal mortality and morbidity due to increased rate of preterm delivery and fetal growth restriction is seen if not well controlled.
Okay, so I think these are very important, figures which you have shown, especially when we have to do the counseling for the patient. So how would you manage a patient of CKD? Suppose she comes in the preconceptional period to you. How will you manage? What kind of counseling will you do for her?
Whenever a patient presents to us for preconceptional counseling, it is always a multidisciplinary approach where the nephrologist, the gynecologist, both are involved. A patient of chronic kidney disease is stratified according to the risk. Firstly, her staging for her chronic kidney disease is done. Her baseline investigations are done. Required investigations include complete blood count, serum creatinine, bicarbonate, electrolyte, liver function test, urine analysis, spot protein creatinine ratio, 24-hour urinary protein, fasting blood glucose and HbA1c to rule out pre-gestational diabetes mellitus, blood pressure measurement and control, assessment of the medications of the patient, and to shift the patient if the patient is on teratogenic drugs to a safer drug, and baseline renal ultrasound is done. After the patient is been staged accordingly and the baseline investigations are obtained, the patient is also explained about the risk that she will face during the conception and after the conception, which are the maternal risk as well as the fetal risk. Deterioration of the maternal health during the course of pregnancy in chronic kidney disease, worsening of proteinuria, ending up in renal failure are to be explained to the patient. The fetal risks like low birth weight, preterm labor, increased risk of perinatal morbidity and mortality, and even the chances of intrauterine fetal death are to be explained to the patient. Once the counseling of the patient is done and she is willing for conception, her maternal risk, fetal risk being explained, all the baseline investigations are obtained and her drugs are reviewed and shifted to non-teratogenic drugs. If required, additional increase in the dose of immunosuppressant may be done, and patient is started on multivitamins and folic acid.
Mm-hmm. And during, you want to drink water, Kajal?
No, ma'am.
You're okay?
Yes, ma'am.
Okay. So then later, how would you do the surveillance during pregnancy?
Once the patient conceives, it is a high-risk pregnancy. So high-risk pregnancy requires adequate and frequent monitoring in pregnancy. The number of antenatal visits are increased, and the patient is called for follow-up every 2 weekly until 32 weeks, and then after weekly till term or when termination is planned. All baseline investigations are obtained and screening is done. The patient is to be screened for urinary tract infections every month and in each trimester. Fetal surveillance include routine screening for the fetal anomalies is done. If there are high chances of the screen coming false positive due to the increased serum beta HCG level due to its decreased clearance. If any screen is found to be positive, it should be always confirmed with an invasive testing. Discussing about the fetal growth monitoring, the fetal growth should be monitored after 28 weeks of gestation every 2 to 3 weeks, and biophysical profile should be done bi-weekly after 28 weeks of gestation. Along with this surveillance, optimization of the patient should be done, and screening for hypertension and preeclampsia should be done. The preventive measures like adding tab EcoSprint 150 milligram HS from 12 weeks of gestation should be done. Patient should be given advice about the nutrition. Diet should be according to the pregnancy, as pregnancy also requires high protein diet, but in cases of chronic kidney disease, we can't give high protein diet, so we can advise her diet which has high bioavailability of proteins. Uremic diet is preferred in these patients, ma'am.
What is high bioavailability proteins?
High bioavailability proteins are those components where there is increased absorption of the protein from that diet into the system. The protein content that the product contains is entirely absorbed into the system, ma'am. Some of the examples of these protein are the egg white, the whey proteins, the proteins present in fish, and some chickens.
Okay. So yeah, about anemia you were saying?
The patients with chronic kidney disease also have concomitant anemia. It may be due to the decreased erythropoietin production from the kidney, as well as increased requirement during pregnancy. So they may be supplemented with iron supplementations. Those patients that do not respond to the intravenous iron therapy, or those who have hemoglobin less than 10, or serum transferrin saturation having more than 25% and ferritin more than 200 nanogram, they can be started on erythropoietin along with the intravenous iron.
Okay, so first you have to make sure their iron stores are good, and then after that you start the erythropoietin if the hemoglobin still remains below 10.
10, yes, ma'am.
That is an important, I think, point to remember, right? And yeah, anything
in patients
else?
with chronic kidney disease who have concomitant hypertension, our main aim to maintain the target blood pressure is 135 by 85 millimeters of mercury. Safe antihypertensive drugs like labetalol, nifedipine, methyl dopa can be added, and those can be increased according to the control of hypertension. Diuretics can be added if there is associated edema or there is reduced GFR. Thromboprophylaxis with heparin is advised if the proteinuria is in nephrotic range.
Right. Okay. So your patient here is already on dialysis.
Yes.
So what are the challenges of doing dialysis in a pregnant woman?
Ma'am, chronic kidney disease with dialysis, women with end-stage renal disease are less likely to conceive, but spontaneous conception may occur after starting hemodialysis. Those who are in dialysis, our aim is to mimic the physiological change that are seen in renal system during pregnancy. The diacylate should be low in sodium and bicarbonate concentration.
Kajal, if it's just reading, then let somebody else read it, you know. You are becoming breathless.
He's having a very bad cough.
Yeah, it's looking like that. So somebody else can read it.
Yeah. Yashi, you can take over.
Yes, ma'am. After the completion of the first trimester, dialysis should be performed daily. A dialysis done for an approximate 20 to 24 hours per week has been shown to give good prognosis in pregnancy. And we have to ensure that the pre-dialysis blood urea nitrogen is less than 50 milligram per deciliter, or serum creatinine is less than 4.5 milligram per deciliter. And fluid removal should be limited to 400 ml per session.
Okay. So basically, it's important cause the fluid shifts, if there are massive fluid shifts and the patient has hypotension during the dialysis, it may lead to, the placental perfusion may be hampered. So that is why to do it every day and to do, not to take out too much of fluid in one session, I think that is very critical. So Dr. Adarsh, we would like your inputs about, this particular problem about women who are pregnant and undergoing dialysis. We have one in our ward right now at the moment. She comes to you people almost every other day she comes.
As mentioned, extensive dialysis should be given, and that is ideally like 20 hours a week, and best is to like 6 hours per day. It will be a 6-hour session dialysis and will be given alternate day, just to make it 20-24 hours. And apart from this, folic acid should be supplemented. And as already told, the erythropoietin should be given to maintain the HP around 10 to 11.
Yeah.
And this is what we need to follow.
This erythropoietin, what it called thrombosis in pregnancy. So what do you advise it in pregnancy, erythropoietin? Or
Yes,
should we give blood replacement?
No. Actually, we need to maintain it around 10 to 11. We should not go beyond 11. If the HP is hemoglobin is going beyond 11 with the erythropoietin, then we should temporarily stop it.
Yeah.
Our target should not be more than 11. But in order to maintain 10 to 11, we need to give. We have no choice.
Okay. Plus, it can also lead to worsening of hypertension, I think, erythropoietin. So that is also one concern. But that is what, that first we give the iron. And if the patient
iron store should be supplemented.
Yeah, they should be sufficient.
Prior to giving.
Prior to giving erythropoietin. Yeah, that is important. So I think you can go to the next slide, Yashi. One more thing is that when we are doing dialysis, patient should be not in the supine position. So, ideally we should put her in the left lateral position, the pregnant woman, so that her circulation, you don't have that supine hypotension. Already when the fluid is taken out, there is a propensity for the patient to have a sudden hypotension. So that has to be prevented. Yeah. Okay.
Fetal monitoring is mandatory after each dialysis session due to acute fluid shifts. The fetal growth scan and umbilical artery Doppler should be performed regularly to look for fetal compromise. Dialysis may be accompanied by preterm labor. However, it is generally transient and resolves without treatment. Delivery should be planned at 34 to 36 weeks gestation, and pregnancy preferably should not be continued beyond 38 weeks of gestation. Infants will experience osmotic diuresis at birth. Hence, careful monitoring and appropriate correction of electrolyte abnormalities should be conducted. Hypocalcemia and tetany in the newborns should be looked for and treated.
Right. So when the baby is born, these may be the problems in the baby also. So they have to be monitored very carefully in the first 24 hours for electrolyte abnormalities. I think this is an important message for everyone. So can you go to the next slide? There is one study about, how many hours of dialysis is recommended, so they found a very interesting observation that if you do, 36 hours of dialysis per week in women with end-stage renal disease, the live birth rates were improved as compared to if you do it for 24 hours. So it is, kind of nowadays, this is the focus, is that you do it as much, as many hours as possible. So 36 hours is as he was saying, Dr. Adarsh, that 6 hours per day. So that makes it 36 hours, So that would be the ideal, but it is very, very difficult actually to follow. What about peritoneal dialysis? Dr. Adarsh, any experience about peritoneal dialysis? We people are not doing here in our hospital, I think.
Yes, so case studies are there for the peritoneal dialysis. And the only difference found with in compared to the hemodialysis, that the chances of preterm delivery are more with the peritoneal dialysis. That's why hemodialysis is favored as far as pregnancy is concerned.
Okay. Okay, fine. So yes, so you can move on to the next. I think it was about management of anemia. So we have already discussed this about anemia. that the role of erythropoietin, we have already discussed that it is very important if the patient is anemic. And target hemoglobin, Dr. Adarsh has said, should be around 11. So 10 to 11.5 we have. And Dr. Malik ma'am has raised the concern about the thrombogenic activity, which is again definitely, so don't try to go overboard with it. If it is 11, then that's enough, we won't go beyond that. And if there is a hemoglobin rise of more than 1 gram in 2 weeks, then the EPO dose must be reduced as hypertension is likely to develop. So these are some important points about the erythropoietin. So next, you can go to the next slide now. Yeah, about the time you would want to terminate the pregnancy and the preferred mode. Yeah, Yashi. So
as discussed, we would like to deliver the patient between 34 to 36 weeks. The preferred mode of delivery is vaginal delivery. However, in high risk patient, we see for a rise in serum creat to estimated GFR. If that is more than 25%, or there is symptomatic hypoalbuminemia, there is pulmonary edema or refractory hypertension. In these cases, we see if the pregnancy is whether it is less than 24 weeks or more than 31 weeks, or whether it lies between 24 to 31 weeks. If it is less than 24 weeks or more than 31 weeks, in both of these cases, we go for termination of pregnancy. However, for the bracket of 24 to 31 weeks, we offer dialysis, and if there is no fetal growth restriction and the BP is controlled, and we try to optimize the hypertension and try to take the pregnancy till 31 weeks. And if we are not able to do that, then we would terminate it. And in low risk patients, we deliver them between 34 to 36 weeks.
Right. So I think this is important is that if it is a viable fetus beyond 31 weeks, we don't want to wait anymore. If the patient is, not is a high risk case, and if it is less than 24, again, no point, the long way to go. But in the others, we try to optimize as much as possible to, gain that time for the fetus. Yeah, but they have to be monitored very, very carefully. Okay, so I think we need to just talk one slide about the pregnancy after renal transplantation, and then we go with the take-home points. Yeah. So this is about postpartum. I think we have discussed already.
Yes,
you can go on to the one slide about the next slide. Yeah. So prerequisite for if the patient has undergone a renal transplant. So what are the guidelines for such patients if they want to have a pregnancy? Yashi, you can read it out.
Yes, ma'am. Ma'am, in the recipients considering pregnancy, we wait for 2 years after cadaver transplant or 1 year after a graft from living donor. The immunosuppression should be at maintenance levels. The plasma creatinine levels should be less than 1.5 milligram per deciliter. The hypertension should be absent or easily controlled. There should be minimal to no proteinuria. Active graft rejection should not be evident in the past 6 months. There should be no pelvic calyceal distension apparent on the ultrasound or intravenous pyelogram. The prednisone, azathioprine, and cyclosporin should be maintained at the doses should be maintained at the maintenance levels for appropriate immunosuppression.
Yeah, so all these three drugs are the safe drugs to continue during pregnancy, basically. So which are the drugs which you should not be giving?
And we should not be given mycophenolate, mofetil, and we should not be given give tacrolimus and sirolimus.
Yeah, so those are absolutely not to be given. They are teratogenic drugs. And once the patient does become pregnant, so next slide you can just show the maternal and fetal risks during pregnancy with renal transplantation.
Yes, ma'am. After renal transplantation, there are maternal risks and fetal risks. The maternal risks are graft loss in 5 to 10% of cases at 2 years postpartum. The rejection risk is 2 to 4%. Hypertension in two-thirds of patients. Infection risk is of 20 to 35%, and the risk of developing gestational diabetes mellitus is 10%.
Yeah.
The fetal risks are overall live birth rate is 75 to 80%. There's a risk of 15% spontaneous miscarriages. Preterm labor labor in 50% cases, and 50% of the cases lead to fetal, in 50% of cases there is fetal growth restriction, and approximately 5% of cases birth defects are seen.
Yeah. So as such, we have not yet managed a case of pregnancy after renal transplant, but I think in the years to come it may become quite common. Dr. Adarsh, have you seen in our hospital? We have not had
No,
a
no,
patient
no, no.
yet. In the practice, I think private practice they are seeing already, but we have not seen in our hospital. Okay, so I think we go on to the last slide. I think take-home messages you can tell us. Yeah.
There are physiological renal changes in pregnancy which predispose to urinary tract infections. All the antenatal women should be screened for urinary tract infection in first visit, or preferably at 12 to 16 weeks with urine microscopy and culture. Asymptomatic bacteriuria should be treated in all antenatal women. Acute pyelonephritis should be treated by inpatient management with intravenous antibiotics. Acute pyelonephritis is an indication of suppressive therapy throughout pregnancy. Timely fluid resuscitation in case of acute hypovolemia is the key to prevent acute kidney injury. With timely detection and adequate resuscitation, changes of acute kidney injury are completely reversible. Chronic kidney disease is not a contraindication to pregnancy. Preconceptional optimization of the patient with adequate control of hypertension has better pregnancy outcomes. Chronic kidney disease requires a multidisciplinary approach. Studies have shown that increased frequency of hemodialysis cycles in chronic kidney disease patients during pregnancy have better outcome. Pregnancy after renal transplant should be planned 1 to 2 years post-transplant and should have no signs of allograft rejection. Optimum blood levels of calcineurin inhibitors should be maintained. Frequent fetal-maternal monitoring should be done. Thank you.
I just wanted to ask one question, especially Dr. Adarsh is also here. Is there any evidence of increased renal stones in the postpartum period, especially when there was a history of bacteriuria in the first trimester? I have recently seen 2 patients. They had a history and then they had renal colic and renal stone in the postpartum period. Is there any precipitating factor or any evidence in the literature regarding this?
A proteus infection is associated with the stone formation. Proteus.
Okay.
Otherwise, in the pregnancy, the chances of stone formation are quite less because there is also increased citrate level in the urine, and that lead to decreased incidence of UTI.
Okay. Okay. So I think Dr. Josna, we have no questions also in the chat, in the question and answer column. So can we finish the session now?
Yes, I think they have summed up very well. All the take-home messages are very pertinent. And there's one question that it is difficult to diagnose preeclampsia, and I think Dr. Sunita has posted that question. We have to check the blood pressure, no? If the suddenly systolic blood pressure and diastolic are increasing more than 30 or more than 15, then we can suspect proteinuria also. If it increases suddenly, then we have to suspect that it could be a preeclampsia, although there could be a worsening of the renal disease also. But ultimately, we'll have to diagnose it on our the parameters which are laid for preeclampsia. Sudden increase in blood pressure and increase in proteinuria.
So on behalf of Delhi PG Forum of AOGD, I would like to congratulate all the our chairpersons and moderators for the hard work. The entire spectrum of the renal disease was covered, right from asymptomatic bacteriuria to chronic kidney disease. So thanks a lot, Dr. Adarsh, and our moderators, Dr. Josna and Dr. Ratna. And of course, our postgraduates from VMMC, they have done an excellent job. So thank you so much. Our next class is on antepartum hemorrhage on 20th February. So I think we will be meeting again. So thank you so much. And Dr. Deepika, last but not the least, we are really thankful to Jagsonpal and Dr. Deepika for taking so much of interest and every minute details. She is so much interested in, so that the class is conducted in a very systematic way. So thank you so much.
Thank you so much, ma'am. And this is from Jagsonpal, the DIVATRONE, our new brand, which won. And the first runner-up is DIVATRONE from Jagsonpal. So this won the AVAX Marketing Excellence Award, being coming in the new launches of India. And the first runner-up is. Apart from DIVATRONE, we request your support for LycoRed, the ultimate cell protector. Maintain injections of 250 and 500 mg hydroxyprogesterone caproate. And we thank you all again and hope to see you again.